What if vomiting or diuretic could secretly tip your blood chemistry and cause dangerous symptoms before you even notice? Today, let's decode how metabolic alkalosis hides in everyday ICU scenarios and what fast diagnosis might save a life. Metabolic alkalosis occurs when your blood pH rises above 7.45 due to the increase in bicarbonate, or rather a loss in hydrogen ions, disrupting a normal pH of the body, which is 7.35 to 7.45. At its core, metabolic alkalosis stems from the two main processes, generation and maintenance. Generation often starts with loss of hydrogen ions from the gastrointestinal tract or from the kidneys. How will one lose hydrogen ions from the GI? Prolonged vomiting or nasogastric tube suction. And how will one lose from the kidneys? By thiazide or loop diuretics. What can also happen is something called as a contraction alkalosis. So the total body bicarbonate remains the same and the plasma volume around it contracts. So this causes a relative increase in the bicarbonate, causing metabolic alkalosis. What can other cause metabolic alkalosis is hypokalemia. Hypokalemia, potassium in the plasma would be low, which will lead the hydrogen to exchange with the potassium so that the potassium plasma concentration of the potassium rises. So this causes a net decrease in hydrogen ions in the plasma, causing causing metabolic alkalosis. How is it maintained? So when this generation happens and the kidney cannot excrete the extra bicarbonate, so it causes maintenance. Why? Decrease in plasma volume, decrease in chloride, or increase in aldosterone levels. What happens next? Increase in bicarbonate, the body compensates by retaining CO2. Hypoventilation, hypoxia. PCO2 rises and PO2 decreases. Neurological most common symptom is confusion. Hypokalemia will cause arrhythmias. And how do you manage it? Do an ABG, identify 2 urinary chloride. If the urinary chloride is less than 20, it's chloride responsive. If the urinary chloride is more than 20, it's chloride resistant. Chloride responsive, more common cause is vomiting. Give normal saline, volume will expand and kidney will be able to remove the bicarbonate. When it's chloride resistant, when it happens is hyperaldosterone and is more associated with hypokalemia. So first, to find the underlying cause, replace the potassium and use acetazolamide if it's needed. If all these therapies exhaust and you cannot get out of this metabolic alkalosis, use dialysis.